Yeah,
So these are the investigations which are available to us. So hemoglobin is 9.5, platelets are 2,34,000. Total leukocyte count is 9,000. Bilirubin is 10 total. Direct is 7.2. Alkaline phosphatase is, ALT is 140. AST is 120. Alkaline phosphatase is 824. Normal limit is 140. Albumin is 3 gram. Gamma glutamyl transpeptidase is 320. So I will. So the next question to Dr. Ashok Chaudhary, sir. Sir, how will you interpret this particular liver function test report?
Ashok,
are you around?
वो सुनाई नहीं दे होगा उसका.
Dr. Ashok sir updated me that he is leaving for some time and then he will rejoin for some family emergency.
Then I'll ask Dr. V.D. Goswami. Can you
Yes.
Yeah, so this is the presentation what we have got now. Bilirubin, mostly it is direct bilirubin. Hemoglobin is less, definitely. Albumin is low. Maybe it is related to alcohol-induced liver disease.
Dr. Goswami, I think it indicates simply cholestatic liver disease. His alkaline phosphatase is raised. His GTKB is raised. It is more than 10 times upper limit of normal. In contrast to AST and ALT, which is less than 5 times to upper limit of normal. Correct. So such a pattern goes in favor of a cholestatic liver disease. And here, as Dr. Akash Shukla had pointed out, there are certain differential diagnosis of cholestatic hepatitis, cholestatic liver disease, hepatitis I told. Right. And he has given a list of cause. So friends, the clinical case that presented to you first is the jaundice. That is step 1, as Dr. Shukla described you on practical slides of his first note. And step 2, what is the type of jaundice? Whether it is a hepatocellular hemolytic jaundice, hepatocellular jaundice, or cholestatic jaundice. This is the step 2 of this individual case, which Dr. Shukla described in his initial introductory lectures. So in the step 2 liver function test reveals cholestasis. That is very important. And as Dr. Shukla had pointed out, cholestasis can be intrahepatic as well as extrahepatic causes. So the next step, obviously, they will try to find out that whether it is an intrahepatic cholestasis or an extrahepatic cholestasis. First thing they will do in such a patient, a simple imaging, which is non-invasive, can be repeated. And that's widely available and less expensive. And that is an ultrasonography. And certain serological marker, right, simultaneously to know whether also intrahepatic causes are responsible. That's what probably the investigation will reveal. That's what you will think. Am I right, Dr. Shukla?
Yes, sir. Completely agree, sir. So in fact, that was the part of the next question, that which of these 4 tests you would do, viral markers, ultrasound, AMA, or liver biopsy. And as you said, very appropriately, sir, we would always do an ultrasound because it is a very simple test to differentiate whether there is a intrahepatic cholestasis or a extrahepatic cholestasis. That is, the cause of jaundice is within the liver or it is in the bile ducts. And with this one simple test, you are right more than 98% of the times. So in such cases, I think ultrasound is the first and the very reliable test to differentiate between extrahepatic and intrahepatic causes of jaundice. And here in this patient, an ultrasound is done, which is not showing any extrahepatic obstruction. The bile ducts are normal. So then we know that although the clinical picture is that of cholestasis, this patient does not have an obstruction, and the most probable cause is within the liver.
What will be the next step in this particular patient with cholestatic jaundice and extrahepatic obstruction ruled out?
So I'll take up this question. So now we know that we are dealing with the cholestasis, that is impaired secretion of bile within the liver. So it is a dysfunction of the hepatocytes or bile ducts within the liver. So then here you would want to, one, rule out common causes like acute viral hepatitis. You would want to rule out other causes of liver diseases like alcohol in this patient. So you would always reconfirm whether the person has been taking alcohol or not. Like Dr. Goswami just mentioned, that alcohol will still be in differential diagnosis, although he claimed that he has alcohol very occasionally, once a month or so. But we have seen this very often, that the patient underreport, and therefore you have to really probe deep into the history. And if you would also do along with that, if you don't find any other cause, probably MRCP to look at the smaller bile ducts within the liver, and also to be sure that the ultrasound has not missed out on obstructive jaundice. So that would be the sequence in such a case.
Akash, can I comment on this? So
Yes,
sometimes what happens in our practice here in Northeast, we used to see patients, those who used to take some herbal medicines, some herbs. So after that, they used to show this type of picture at the same time. So there may not be any obstruction. Ultrasound is normal, but bilirubin is high. It may be mostly the direct bilirubin, but there is a history of some herbal medication. So probably we have to take that question to the patient also, because initially they used to ignore it, or they used to refuse it to take. But that is, I think, important point for the history. Is it?
right.
Is it?
I agree completely, sir. I think it's everywhere. We do face patients who have consumed alternative medicines or herbal herbs, some, and very often on their own without any doctor's prescription, and then they'll end up with jaundice where no other explanation is found. Completely agree. Can we move on?